Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And we're going to talk to you about a very interesting, new, innovative delivery of healthcare. Actually, the title of the program is Optimal Health Innovation in Healthcare Delivery. And we have two experts here. We have Dr. Arthur Agatston, which is sort of, if I remember the word Livingston, as your wife told me, I'm going to use the word Agatston. And you are the, I guess, the director and the founder of the Agatston Center for Private Medicine. Welcome.
Thank you. Good to be here. Also
famous for creating the South Beach Diet, which I think a lot of people see on television all the time. And we're very happy to have you, sir. Thank you. And Dr. Judy Woolgar, who is an internal medicine physician, and she also works at the Agatston Center for Private Medicine. Welcome.
Thank you very much.
Good to have you. So tell me, Dr. Agatston, what is different about your Center for Private Medicine?
Well, it's good to put it in the context of what's been happening in medicine over the last many years. And I grew up with a father who was a doctor pre and post Medicare. My grandfather was. And I've watched the evolution, first of the culture of medicine. And going into even pre-Medicare days, doctors didn't necessarily make a lot of money, but they loved what they did. They worked long hours. That's back to the Marcus Welby for your audience that remembers him. And that was kind of the real deal. After really government and regulation and big insurance companies became involved, the cost of healthcare went up, regulations came in, and today doctors don't work for themselves. They've lost their autonomy. Doctors, going back to Marcus Welby, he quarterbacked the care of his patient. So you needed a specialist. They spoke to the specialist before the consultation, after the consultation, and everybody was really on the same page. Today, nobody has time. So the communication is horrible, and often patients are quarterbacking their own healthcare. So they have to go to an orthopedist or a neurologist. They ask a friend and make the appointment directly. And when they go there, if they have their records, documentation is another big problem. Today, because of regulations and documentation, the caregiver has to spend all this time documenting things, physical exam, which are not important. But when a patient takes that medical record to a consultant, they can't find that he had a headache because he was missing sleep because of pressure at work. It's a needle in a haystack of all this stuff that's written for documentation. The consultant doesn't usually communicate back to the primary care doctor. And there's plenty of technology that allows us to do it, but it's just not being done. We're not taking advantage of the technology. And because of the time constraints, the documentation constraints, primary doctors and others are just putting out fires. They're putting out the problem. And the problems often come from issues that they don't have time to address. And so we are changing a lot. One, when we talked about optimal health, we are concerned with the patient's nutrition, how they're sleeping, how they're exercising, their psychological life with family, with things like mindfulness. Are they taking time off? So we address all of these issues. By the way, the best examples I like to use, people know about Djokovic, the tennis player. Djokovic, about 8 years ago, was number 3 tennis player in the world, behind Nadal and Federer. And people said he didn't have the toughness, He couldn't win the long matches. He just wasn't good enough. He realized on his own it was his diet. He went off of gluten and he became #1 in the world. Now, here's a guy, a great athlete. Nobody would say he's sick, but he wasn't in optimal health. Similar happened in a ice skater many years ago, Sarah Hughes. They thought she was the best skater. She could never win the gold. She was getting up early in the morning for practices until she met a very good sleep physician who said, forget that early morning workout, you need enough sleep. She got enough sleep. She won the gold medal at the 2000 Olympics. So these are two cases of people who, they're not sick, they're among the healthiest athletes, but they're not at optimal health. So in our practice, we work, first of all, we give a lot of time to the patients. We know the patients, we know their spouse, their family, we know what's going on. We follow up and communicate with consultants with video. We call them collaborative consultations. So if we send the patient to a consultant, the introduction is made by video where we give the whole history of the patient. And the consultant can ask if the patient is there, they could have their Uncle Harry doctor with them, coming in from someplace else. These kind of consultations can be international, across city, within the same city, but the consultant is on the same page, and then our office, which knows the patient and the family, we carry out the instructions, the advice of the consultant. So we're not dumping the patient on an office that doesn't know the patient. And then we communicate with the patient, both often with video or with phone. They don't have to come in every time. And so that communication is much better. And we use technology to monitor what's happening in their home. So when they're weighing themselves, checking their blood pressure, they send it in to us. We're working on a method where, with a dashboard, how they're sleeping, their blood pressure, their weight, all comes into us. And if their weight's going up, if there are issues, we get an alarm, and we can intervene before the issue becomes an emergency.
Well, Dr. Woolger, I don't know what you got left to say.
We do a lot.
But go right ahead. It's all yours.
Well, I think the innovation with what we're doing is really the time, because we're spending the time with patients and giving them that personal attention that we've lost when you get a 20-minute appointment with a primary care doctor. Much of it is spent, as was said, on the documentation or just getting through the basics of what's, we don't forget your mammogram and your colonoscopy and the things that are required. But there's not that delving into what's going on with you personally, with your family, things like that.
We have such a huge shortage of physicians around the nation, and we have multiple closings of rural hospitals and what I would call not primary care hospitals, but I would call them almost really tertiary care hospitals that were acting as primary care venues. So the whole healthcare system is changing because it's really driven by metrics. It's driven by math. It's not necessarily driven by need. And that's my opinion. It gets very difficult because, like I said, healthcare has become the dedicatory thought process of math. And then, I don't blame the physician community for having to run through patients because they're trying to obligate themselves to high rents, the cost of running a practice and doing everything else. I mean, the Marcus Welby consideration of living in a little cottage on the countryside and driving a 20-year-old car is not the reality of what we have. Again, I don't mean to dominate this conversation, but Dr. Woolgar, what I'm telling you is the people out here who are crying for a more respectful and long life are saying, how do I take care of myself when they can't afford the nature of their healthcare needs? Now, I was hoping that you both would get into, and I know you will, because I know that the issue is not just the bureaucracy of healthcare, but it's the utility of your knowledge that enables your patients to be not only viewed relative to the metrics of their blood pressure and the blood tests and whatever, but is to measure the amount of sleep, to understand their nutritional intake, to understand the nature of how everybody's body, the mass of protoplasm that consists our body is different. Correct?
Correct.
Go ahead, Dr. Woolger, it's all yours.
We do spend a lot of time on that because we like to give the power back to the patient. Instead of saying you're dependent on this pill to make you better, here are things you can do for yourself that will make you better. It may be eating differently. It may be avoiding certain foods, avoiding sugar, avoiding processed carbohydrates. It may be sleeping more. It gives the power back to the person to figure out what is going to make them feel better and let them participate in wellness for themselves.
Well, not to get too inappropriate, how does one pay you for the visits that they provide?
Well, our practice is private, and the patient pays a yearly fee. Now, we tried to bring what we're talking about, the technology, the optimal health, to groups within more general care, within underserved, and frankly, we couldn't overcome the current regulatory atmosphere. So we're developing our private medicine in really the only place that's not regulated. So we don't deal with insurance companies at all. And I would argue that even after the patient pays the yearly fee, we use less healthcare dollars than anybody because we avoid unnecessary consultations, procedures, and so we're actually saving money, and by the prevention that we do. About 50% of people who are taking statin drugs today don't need them by national guidelines because they have a 0 calcium score. That's the test I developed to look for early arteriosclerosis. And it's now just in the national guidelines. If you don't have any calcium in your coronary arteries, it's a simple 5-minute test, costs $99, then you're at very low risk for a heart attack, even if your cholesterol is high, and you don't need a statin. So that's one area with one simple, inexpensive, safe test. You can save years of statin treatment. Now, other people need various interventions. We tailor our medicine, so we look for if there's a problem, if there's plaque, if there's high blood pressure, what's really causing that high blood pressure. If it's lifestyle issues, we do have the time and we work on the lifestyle. In the end, this is actually very cost effective. And I agree with everything you said, Dr. Lippman, about what's happening with primary care doctors. And I know one thing you do here at Nova Southeastern is you emphasize the primary care doctors and the quarterbacks, but the system has made it so hard for them to practice that patients don't often bother to go. They go directly to the specialist when they often don't need it. And that's where all kinds of cost and poor communication come in. We have to bring the primary care doctor back. And it can be done. It's being done around the country, something called direct primary care, which is quite affordable. People pay a certain amount per month to a primary care giver. And I think it's really outside the system. You absolutely can do excellent care at lower cost. But you have to get rid of the bureaucracy.
Let me just tell you that I think that the founder of our venue, Dr. Morton Terry, always felt that physicians, now he was an internist cardiologist, and he always felt that the biggest problem that he had was the genuine disrespect that some health professionals had for other health professionals. And he felt that in building the health professions division, that there would be this interdisciplinary collaborative venture, which is our education unit, and no one would be treated differently. In other words, if the pharmacist, the optometrist, the dentist, the doctor, the nurse professional, the physical therapist, et cetera, et cetera, et cetera, if everyone understood that they have to communicate and collaborate and cooperate with these individuals, then the cost of healthcare would be dramatically reduced, all right? Now, what we've done is we've introduced a lot of what I would say, not innovative, just I would say really common sense things, such as nutrition, exercise, mind, body, spirit issues into our curriculum. So we feel, and again, I'm justifying and I'm protecting the many people that we put out there. Yes, they end up in these high-end tertiary care institutions where this is the protocol and this is what you have to do. But I don't ever think they lose that commonality of respect for the other professionals that are around them.
That's a brilliant way to train people. Absolutely. I think we learned early that in our training you always made nice with the nurses because they know everything. So we do need to collaborate.
Well,
so the way you're training
especially in what we have developed in this country are wonderful, excellent facilities, but they are highly skilled tertiary care facilities, critical care facilities, and the nurse professional is really there. I mean, one of the elements of the nursing staff is there to really either follow directions of, observe, and act upon about 85 and 90% of the healthcare.
I couldn't agree with you more with the approach and the communication. And it's not that doctors don't want to communicate, it's the time and the pressure coming from the time they have to spend with documentation when they have 20 patients in the waiting room. And the type of approach we're taking, I think, would work in the underserved today. If you paid the primary care doctor adequately and made it easier through technology for him to get help, our collaborations with video we have excellent relationships with our consultants. But our patient is paying, and it's a fair market value. It's not outrageous for that doctor's time, and we're not dumping the patient on their office, taking up overhead and other time. We know the patient. Why repeat everything that we know? So we tell the consultant what's important, we get the consultant's advice, and then we carry that out. So it's very cost effective, and the consultants love it because we're giving them, we want their knowledge, their advice. We don't want to tax their overhead and their office.
Well, I understand that, but let me challenge something here. And I'll challenge it to you, because he's going to give me an answer that might be different than your answer. Dr. Agatston said before, well, it's a simple test, you know, do a calcium test, $99, and you get it done. What about the person that doesn't have the $99?
There are sites that do it less expensively, like during Heart Month. Usually it's free or half price. So that's February coming up.
For the system to figure this out, I mean, the $99 is very cost effective. It prevents unnecessary stents, bypass surgeries, years of medication, and you know we can do that relatively easily. Now, you know, in my practice, when I've had teachers, police, it's interesting. And originally the calcium score cost quite a bit more. And I would convince them that this should be an investment in their health, in their future. And they were often much more willing to pay than some of the rich people who were more difficult with wanting to spend money.
If I was mom and my husband is driving a truck, God bless him, and is delivering products from Publix to my house or Walmart or whatever, or any one of the beautiful, wonderful venues, and I have to make a decision because my kid's going back to school and I want to buy him new shoes. I may not have the $99. So what do? Because I have pain, or I don't. I mean, just before you were here, we had an interventional cardiologist was here. He's talking about a case of a 33-year-old female who had absolutely no indications at all, and she had a 94% blockage of the LAD. 33 years old.
The great majority of people do have warnings. You develop plaque in your coronary arteries years before you have a heart attack or stroke.
Does that mean that we discount the people who don't give us the warnings?
No, they don't have symptoms. The majority of people, when they have a heart attack or sudden death, it's the first warning.
I understand.
But for instance, in the Miami Beach Police Department a few weeks ago, one of their officers, who they considered very healthy, dropped dead suddenly in the police gym of a heart attack. And he had a negative stress test a few weeks ago, which was the wrong test to do. But he, on the autopsy, he was filled with plaque, which included calcium. He could have been detected 20 years ago, 10 years ago, and this all could have been prevented. So this is part of preventive cardiology, and you'll never get 100% of people, but what's much more cost effective than knowing your cholesterol, for instance, is knowing your calcium score. And this is because it's not covered by insurance. I can't tell you all the reasons, but it's simply that you develop arteriosclerosis years before it causes a heart attack or a stroke, and we can detect it. Pretty simple.
Well, I think Dr. Woolger's got the answer, but we're down to the last 3 minutes of the show, so you want to give me an answer in 1 minute?
An answer to which question?
That last question, that last statement about the person with the calcium problem. I mean, it's nutrition.
Well, I'm a big fan of changing diets.
Right.
Changing diets. Sugar is probably the enemy, a poison.
Right.
Processed carbohydrates are not good. In our office, we're big fans of keto-friendly,
Right.
which is staying with the proteins and some fats, but really cutting out the sugars and carbohydrates.
That's a South Beach diet.
It's a prolonged phase 1 of the South Beach diet, yes.
Right.
Yes, it is.
See, you don't think that I know about the South Beach diet. We could really talk about this subject for another couple of shows, and I'm going to have you back if you would allow me to. Sure. Because I think we need to get a little bit beyond the philosophy issue or the dependence upon what's right and what's wrong in healthcare. I'd really like to do a lot more about what we should do as human beings to make ourselves healthier. And so I'm going to give you a minute just to throw that in, Doctor.
Sure. I mean, that's what we emphasize is optimal health. So, I mean, right now we're in the midst of a continuing obesity, diabetes, heart disease, cancer epidemic. And to me, it all started when we changed national guidelines to less fat and brought in the sugar and the processed carbohydrates. And so it does cause obesity, but it causes diabetes, heart disease, more cancer, all kinds of problems. And more than half of the population is diabetic or pre-diabetic. Sometimes they may not be overweight. They're just overweight in their belly, what we call normal weight obesity. So the nutrition is really important. Of course, exercise, fitness, the way you exercise, core exercise, interval exercise, getting enough sleep is important in so many areas. For one thing, if you're not getting enough sleep, you're going to be hungrier you're going to want to eat
And
more.
my expert would tell me hydration too. So I'm going to tell you, Lynn Lafferty always tells me
Especially in South Florida.
right, South Florida. I'm sorry to cut you off, but we're down to the last 30 seconds. So, Dr. Woolger, I know you're a big proponent of nutrition and certain nutraceutical utilization, things of that nature. And I want to thank you very much for being here.
Thank you for having us.
No, I thank you both for being here. It's a subject matter that needs more time and declaration, and I promise you that we'll have you back again if you would allow us to have you back again, okay?
Would love to. Thank you very much.
Thank you.
We really
Folks,
enjoyed it.
I hope that we answered some of your questions relative to, again, you know, what's going on. We hear so much from you about obesity and diabetes and things of that nature. I think we just got a little tab in our book to say, wait a minute, we got some answers here. So we're going to have these folks back. But I want to thank you for showing up again this week. Remember, this show is your show, and if you have any questions and you want any answers, well, just give us a call or get us a little note on our email address. And remember, this show is your show, so if you have any other questions or items that you want to talk about, just let us know. We come to you from Nova Southeastern University. This show is called Dateline Health. My name is Fred Lippman. Until next time, see you.